Great. Good evening. First, thanks to the organizing committee for this industry symposium, also the Eris Pharma for asking me to chair a very powerful, discussion. Going to be by a legend in diabetes from Trichy, Dr. Shanmugha Velu. I think you can read. And this is fully a synopsis. I think you'll go to pages. His things. So, cut short. He's a well-known friend of mine. He's my mentor also, and I also asked him to consult once to how to form the Diabetes Club of Madurai, following Trichy Diabetes Club. So he has been always been my advisor. So I'm very happy, very privileged to chair this session where we got very important topic to discuss about the HLD emitters. Of course, there is no symposium, there is no CME on diabetes without HLD inhibitors. And every day they are discovering some new aspects of HLD inhibitors. It was discovered as a diabetic drug, but today is, to be practical, to be frank, it is going away from diabetes. It is going away from diabetes. Yesterday I read one paper that HLD inhibitors are useful for this hyponatremia, for outpatient hyponatremia, because this syndrome of inoperable ADH induced hyponatremia was responding to these HLD emitters, even in non-diabetic patients. So every month or every week, we are discovering some new aspects of HLD inhibitors, apart from diabetes. And even recently, some of my colleagues are there. I have spoken on 14. The last, my number was 14. I don't know, it has gone to 15 non-glycemic benefits of HLD inhibitors. So today I'm very happy to present this HLD inhibitors, the statins of the year. The statins of the year, this is HLD inhibitors. So I welcome Dr. Shanmugha Velu to present his deliberations on this topic.
Respected chairperson, senior doctors, my doctor friends, and of course, former friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on SGLT2 inhibitor, the statins of the 21st century, with a particular focus on evidence and outcomes. So I thank our chairperson, Dr. Gopinath, my friend, for his generous introduction. Also thank the organizing committee members, Dr. Kumaravelu, Dr. Manikandan, Dr. Anand Kumar Annamalai, and others for their kind invitation. I also extend my sincere thanks to Eris Pharma. Right, my disclosures. So what I'm going to do for another 40 minutes, SGLT2 inhibitors, the statins of the 21st century. We know pretty well. Type 2 diabetes is a multi-causal heterogeneous progressive cardiometabolic condition. It's a major risk factor for atherosclerotic cardiovascular disease, heart failure, as well as CKD. Despite major therapeutic advances leading to improved outcomes over the past 2 decades, cardiovascular disease remains the major cause of morbid mortality in patients with type 2 diabetes. So the development of treatment strategies to improve the cardiovascular outcomes in this vulnerable patient population remains a major priority, not only cardiovascular outcomes, but also CKD outcomes, heart failure outcomes. So the progressive complexity of type 2 diabetes. So type 2 diabetes, progressive disease. So multiple intervention will need to be used while managing diabetes as the disease advances. So there is a need to modify and individualize anti-hyperglycemic regimens in order to improve glycemic control and also delay the advancement of the CKD, as well as heart failure, as well as atherosclerotic cardiovascular disease. So new agents proven to reduce adverse cardiovascular outcomes, renal events, as well as heart failure outcomes in patients with the type 2 has triggered a major paradigm shift beyond glucose control to a broad strategy of comprehensive CV risk reduction. So SGLT2 inhibitors, the statins of the 21st century. This particular statement was issued, released by the Department of Medicine, Harvard Medical School. My question is, can we all consider SGLT2 inhibitors, the statins of the 21st century. Let me take all into evidence, and at the end, I'm going to ask our chairperson whether he is going to agree or disagree on this particular statement issued by the Harvard Medical University. So, relatively small number of drugs have been responsible for major advances in medical practice. So, the discovery, development, and elucidation of the mechanism of actions of aspirin, penicillin, and statins are remarkable, with the success stories, each with some surprises and each crowned by Nobel Prize. So the SGLT2 inhibitors has been proven effective in the treatment of type 2 diabetes, various forms of heart failure and kidney failure, and represent the or one of the major pharmacological advances in cardiovascular medicine in the 21st century. So if we look into the prevalence of cardiovascular disease in patients with the type 2 diabetes with reference to stroke, myocardial infarction, heart failure, coronary artery disease, and overall CVD. So what is the reason? So the CVD is a major cause of comorbidity and death among patients with the type 2, with the CAD having the highest prevalence. So this particular study, I care for diabetes survey, this particular study highlighted the importance of prevalence of CKD risk in Indian patients with the type 2, 58.7% of patients with the type 2 in the Indian patients, outpatient setting, having increased high CKD risk. If you look into the publication from All Indian Institute of Medical Science as well as Bhubaneswar, they also confirmed the similar prevalence. And based on the G, that is based on the EGFR categories, we have these G1, G2, G3, A, B, as well as G4 and G5. Based on albumin categories, urinary albumin excretion, A1, A2, A3. And based on that, we have low risk, moderate risk, high risk, and very high risk. So this particular study is very important. This was published in Diabetes Cat 2019 December. This literature confirms that strict glycemic control, keeping the A1C less than 7 in the first year, significantly reduces the risk of macrovascular events and mortality. The so-called the impact of early glycemic control on future complications. So A1C levels greater than 6.5 for the first year after diagnosis demonstrated what's outcomes among patients with the newly diagnosed patients and 10 years of survival in comparison with the A1C less than 6.5 for the first year. So longer periods of exposure to A1C levels greater than 8% were associated with increasing microvascular event and mortality risk. So strict glycemic control, risk reduction with the A1C level less than 6.5 versus between 7 to 8%. If you look into the microvascular risk reduction, down by 39%, microvascular 29%, death 29%. If you see the p-value, it is statistically significant, thereby demonstrating, highlighting intensive treatment for newly diagnosed patients might be necessary to avoid irremediable long-term risk for diabetes complications and mortality. So typical Indian patients phenotype, we have thin fat Indian, high visceral fat, higher insulin resistance, high inflammatory markers, and characteristic dyslipidemia, high risk for diabetes complications, as well as the cardiovascular risk, early decline in beta cell function. So we need to prescribe, because these are all the common patients we come across in our day-to-day practice. If you look into the efficacy of modern diabetes treatment, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor in white compared to Asian patients with diabetes. So SGLT2 inhibitors, Asian versus white, based on the number of studies, the glucose-lowering efficacy of SGLT2 inhibitors and to a lesser extent DPP-4, it was greater in studies of predominantly Asian ethnicity. So there is a definite role for us to prescribe both SGLT2 inhibitors followed by DPP-4 inhibitors in addition. So if you look into the glycemic efficacy, SGLT2 inhibition, that is stronger in Asian patients with the type 2 diabetes. So in Asians, in whites, if you see from the baseline with reference to A1C reduction, there was significant, and p-value is also statistically significant compared to DPP-4 in Asians and whites, where it did not reach statistical significance. So the difference in response, they are more likely to reflect phenotypic or pathophysiological differences. So ominous octet, multiple factors contributing to overall hyperglycemic patient with the type 2. If you look into the SGLT2 inhibitors, they inhibit renal glucose reabsorption, increases lipid oxidation, improves insulin sensitivity, at the same time increases physiological levels of glucagon, accounting for increased endogenous glucose production. So these are the challenges we come across in our Indian patients, and there are relevant SGLT2 related inhibition features. So low adiponectin level, high insulin resistance, low level of adipokines. When you prescribe patients on SGLT2 inhibitors much early. We can correct the basic pathophysiological abnormalities underlying type 2 diabetic patients. So this is very important slide. SGLT2 inhibitors improve insulin sensitivity. How? It increases urinary glucose excretion. There is a change with reference to insulin glucagon ratio with an impact, beneficial impact on the liver metabolism, adipose tissue metabolism, skeletal metabolism. In that, it reduces the triglyceride content, favors glucose uptake, thereby it improves the insulin sensitivity. In the long run, it also improves the beta cell function based on the fact that it increases urinary glucose excretion. There is reduction of glucolipotoxicity with a favorable impact on the beta cell function as well as beta cell mass. Thereby, it is able to preserve the beta cell as well as beta cell function as well as mass for a longer period of time. So this is the ultimate metabolic changes following inhibition of SGLT2 inhibitors. It reduces the glycemic parameters, number one, reduces adiposity consequent on increased urinary glucose excretion with an impact on adipose tissue. Next is pancreas, altering the insulin glucagon ratio, as well as favorable impact on the metabolism of liver, as well as the substrate switch in cardiac myocytes, as well as in the brain. So it increases the fat utilization. In that, it stimulates the AMPK related activity in the skeletal muscles. It enhances browning, that is differentiation of brown adipose tissue into white adipose tissue into brown adipose tissue. Thereby, it increases thermogenesis as well as energy expenditure. Besides, there is change in the polarity of M2 as well as M1 macrophage. M2 is anti-inflammatory, M1 is pro-inflammatory. There is a change with reference to polarization. Next is SGLT2 inhibition modulates NLRP. It is nothing but a pyrin containing domain which plays an important role in inflammation. It stimulates the release of interleukin 1 beta that in turn accelerates atherosclerotic process as well as heart failure risk. And that SGLT2 inhibitor attenuates this particular pathway. It reduces epicardial adipose tissue. That is the fat that is located between the visceral pericardium and the myocardium, and that it has a favorable impact on the epicardial tissue. Thereby, it reduces the incident rate of atrial fibrillation. This is how the epicardial fat increases the incident rate of atrial fibrillation. Patient with the diabetes, they are prone to develop atrial fibrillation, and it increases mortality, increases the CVA. There is cerebrovascular accident risk. Not only that, it also carries worse prognosis. So epicardial fat, it produces inflammation, oxidative stress, and also alters the electrical as well as structural properties of the pulmonary vein as well as atrial vein, increasing the propensity to develop atrial fibrillation. So sympathetic activity, it attenuates sympathetic activity, especially to the heart, to the blood vessels, to the kidney, with a positive impact on the renin-angiotensin aldosterone system. Also, it has an impact on the neprilysin enzyme. Thereby, it increases the natriuretic peptide and positive beneficial effect mediated by natriuretic peptide. These are all the mechanisms giving rise to reduction in the blood pressure. In that, it alters the hemodynamic mechanism. It induces diuresis, natriuresis. Next is decreases body fat, decreases uric acid, decreases the sympathetic activity as well as the arterial stiffness. Next is it significantly reduces hepatic fat content in patients with the type 2 diabetes and non-alcoholic fatty liver based on the LIFT study. So this particular study, if you see the baseline compared to control and patient on EMPOWER, there was a reduction in the hepatic content as well as there is a change with reference to the liver enzymes. Next is GLP-1 receptor agonist and SGLT2 inhibitors significantly improve the biomarker of hepatic steatosis, that is fatty liver index, as well as fibrosis. So the fibrosis score 4, there is significant improvement. And SGLT2 inhibition in non-alcoholic steatohepatitis and type 2 diabetes, possible histological improvement with reference to inflammation, with reference to ballooning and other pathophysiological abnormalities characteristic of non-alcoholic steatohepatitis. Next is obstructive sleep apnea. Patient with obstructive sleep apnea, they develop diabetes. Patient with the diabetes, when they develop obstructive sleep apnea, they carry very high risk, cardiac risk. So patients participated in the EMPOWER outcome trial. There was 52% lower risk of new onset obstructive sleep apnea. In that, SGLT2 inhibitors in patients with obstructive sleep apnea showed a significant reduction in hypopnea index. Thereby, it modulates the mortality or morbidity due to cardiovascular illness. So, if you look into this three-dimensional view of the tongue, so red indicates the tongue muscle and the yellow color indicates the fat that is deposited. So, by putting the patient on SGLT2 inhibitors, the retropalatal and retroglossal deposition of fat, there is regression. Thereby, it improves the pharyngeal airway and pharyngeal air pathway. So, the rostral shift of the fluid in the interstitium. SGLT2 inhibitors compared to furosemide. Furosemide reduces intravascular as well as interstitial. In contrast, SGLT2 inhibitor has differential volume loss. So, interstitial fluid volume loss in comparison to blood volume. So, such a differential volume loss may have relevant clinical implications on reducing congestion, which is subjected to further research. So, cardiorenal implications of SGLT2. So, diabetes through hyperglycemia, hyperinsulinemia, insulin resistance, that results in AG accumulation, glucolipotoxicity, as well as alteration with reference to metabolism, ultimately resulting in myocyte apoptosis, fibrosis, and left ventricular hypertrophy, greatly increasing the risk for cardiac myopathy. So, maladaptive pro-inflammatory response for this progression of diabetic cardiomyopathy. If you look into the mechanisms underlying diabetes and heart failure, so diabetes is a condition characterized by metabolic overload, number one. Number two, hemodynamic overload, which then results in ionic disturbance, inflammation, oxidative stress, that results in mitochondrial cytopathy, contractile dysfunction, vascular dysfunction, cell death, and heart failure. So that is a predominantly mechanism. So if you look into the patient with the type 2 diabetes, there is glucolipotoxicity because glucose is not utilized properly, lipids are not utilized properly. That results in endoplasmic reticulum stress, oxidative stress, and inflammation. That results in dysfunctional mitochondrial cytopathy. Normally, these organelles are cleared by a process called autophagy. In patient with the type 2 diabetes, there is impairment of this particular autophagic reflex, leading to the accumulation of the dysfunctional organelles. So that is the main cause for triggering cardiomyopathy or glomerulopathy or tubulopathy. So enhanced nutrient and oxygen deprivation signaling, that results in autophagy, that results in mitochondrial stabilization as well as suppressing inflammation, oxidative stress, and that in turn increases the ATP production. So the dysfunctional organelles are cleared. So SGLT2 inhibitors, that stimulates the nutrient deprivation signaling. We get two important co-transporters, namely SIRT1 and AMPK pathway. That in turn results in reduction in inflammation, oxidative stress, prevention of organelle dysfunction, as well as slowing of the development of cardiomyopathy, as well as nephropathy. So these are all the plausible mechanisms responsible for SGLT2 associated cardiovascular benefit. Number one, natriuresis, reduction in that is interstitial edema, differential volume loss, preload reduction, afterload reduction, and reduction on the left ventricular wall stress, improve renal function as well as cardiorenal physiology, inhibition of cardiac sodium hydrogen exchanger. That is very important. So, SGLT2 inhibitors differentially impact the interstitial and intravascular fluid compartment. So, selectively reduce the interstitial volume, thereby it relieves signs and symptoms of interstitial congestion, provide relief of elevated cardiac filling pressure. Next is in the cardiac myocytes, we have the sodium hydrogen exchanger 1. That increases the intracytoplasmic sodium and also interface with the calcium in the mitochondrium. And that is associated with the defective cardiac contraction. It restores, that is effect of sodium hydrogen exchanger blockade on improving the mitochondrial metabolism. Equally important is the vascular effects of SGLT2. It improves the mitochondrial function, improve the viability of endothelial cells, improve the nitric oxide activity and the vasorelaxation. Next is with reference to left ventricular remodeling, which plays an important role in cardiac myopathy. In patients with CAD and type 2 diabetes, so this particular SGLT2 therapy has been associated with reduction in the left ventricular muscle mass index as well as left ventricular extracellular volume fraction. Next is atrial arrhythmia. So atrial arrhythmia carries bad prognosis, and it is associated with the worsening of heart failure, increasing the risk for CV event. So patients treated with the dapagliflozin in declatomy showed reduced incident rate of atrial fibrillation. Next is patient participated in the EMPA outcome trial. Ventricular arrhythmia, sudden cardiac death, both were reduced in patients in the EMPA arm, probably due to related to the reduced risk of arrhythmia or sudden cardiac death. Next is with reference to various trials, with reference to EMPA-REG, Canvas program, canagliflozin, decletimy with reference to DAPA and VET-CV, in patient with the type 2 diabetes and atherosclerotic cardiovascular disease, with reference to MACE, CV death, all-cause mortality, as well as hospitalization for heart failure and chronic kidney outcomes. So patients treated with SGLT2 inhibitors, patient with atherosclerotic cardiovascular disease, established cardiovascular disease, EMPA should benefit with reference to cardiovascular death, as well as hospitalization for heart failure or chronic kidney disease. Dapagliflozin, in patients with multiple risk factors, no improvement at all. In patient with established cardiac vascular disease, there is to some extent reduction in cardiovascular death. Next is, as per statistically robust meta-analysis of reduced ejection fraction failure, SGLT2 agents consistently reduce the risk of CV death, number one. Number two, hospitalization for heart failure. So EMPA reduced, EMPA in patient with reduced ejection fraction failure. Next is DAPA heart failure with reference to DAPA heart failure. In patient with diabetes, there was significant reduction in hospitalization for heart failure as well as CV death. Next is patient without diabetes. When given these two drugs, there was significant reduction in composite of cardiovascular death as well as hospitalization of heart failure. No worry regarding the hypoglycemia. So these particular agents are useful in the management of heart failure with reduced ejection fraction, regardless whether they have diabetes or not. So next is this particular sotagliflozin. In patient with reduced ejection fraction, in patient with preserved ejection fraction failure also, there was significant improvement. So this is EMPA preserved study. Patients were randomized to receive EMPA and placebo. The composite endpoint, that is time to first event of adjudicated CV death or hospitalization for heart failure in patient with ejection fraction greater than 40. So many drugs have been tried in the management of preserved ejection fraction failure. But this is the first clinical trial which demonstrated the fact that putting the patient on EMPA showed significant improvement with reference to cardiovascular death and hospitalization for heart failure. So EMPA demonstrated clinically meaningful 21% relative risk reduction. So the number needed to treat 31. So if you treat 31 patients, we can prevent one event. So in the composite primary endpoint of CV death. Next is secondary endpoint. Again, there was significant reduction, 27%. So patients with heart failure, preserved ejection fraction failure, EMPA preserved, you can see the risk reduction 21%. If you see the p-value, it is statistically significant. Next is Paragon heart failure, sacubitril/valsartan combination. It showed 13% reduction. Next is TopCat, spironolactone, 11%. Next is I-Preserve, 5%. Next is PEP-CHF, all-cause mortality, perindopril, just 8%. Charm preserved, candesartan, 14%. So this is the first trial which clearly showed. Next is summary of studies in patients with recent heart failure. So heart failure with reduced ejection fraction, preserved ejection fraction, patient with diabetes, patient without diabetes, in hospital treatment initiation, solaized with reference to sotagliflozin. Next is with reference to pioneer heart failure as well as impulse. So these are all the trials with various drugs. So EMPA preserved, breakthrough results. So for the first time in medical history, treatment showed beneficial outcomes in patients with heart failure, preserved ejection fraction by reducing the risk of hospitalization for heart failure or CV death. The benefit was independent of ejection fraction and consistent across further subgroups. So EMPA not only played important role with reference to the composite of CV death and hospitalization for heart failure, it also protected the kidney by slowing the decline in kidney function, that is doubling of serum creatinine, or persistent decline in eGFR less than 40%, or end-stage renal disease, or the need for renal replacement therapy, or renal death, or all-cause mortality. So the treatment of heart failure, preserved ejection fraction failure, EMPA would change the clinical practice. So decoding EMPA molecular mechanism of action. So the most probable cascade mechanism in heart failure with preserved ejection fraction with 94% accuracy. One is it reduces oxidative stress in cardiac myocyte, systemic inflammation, cardiac myocyte stiffness, extracellular matrix remodeling, and concentric hypertrophy. So these are all the hypotheses that has been generated with reference to improvement in preserved ejection fraction failure. It also improves diastolic function in common heart failure with reference to diastolic stiffness. So non-failing myocardium compared to patients with heart failure with preserved ejection fraction, you see the improvement with reference to the diastolic function. Patients treated with the MPOG, the p-value is statistically significant. So these are the possible mechanisms detailing why SGLT2 inhibitors may work in heart failure with preserved ejection fraction. It reduces the ROS activity, reduces sympathetic nervous system activity, reduces inflammation as well as oxidative stress. So SGLT2 inhibitor improved cardiac structure and function by reducing preload. Next is afterload with a positive beneficial impact on myocardium in terms of efficiency as well as contractility. So the estimated clinical benefit. So heart failure with reduced ejection fraction failure. We normally put the patient on ACE inhibitor or ARBs plus beta blockers plus melanocortical receptor antagonists and various other treatment drugs. So we have the foundational therapy as well as novel therapies. So patients treated with ARNI, beta blocker, MRA and SGLT2 inhibitors. Look into the CV mortality, 64% improvement compared to treatment without SGLT2 inhibitors, including RNA, beta blocker, MRA and other drugs that are used in the management of heart failure. So this particular drug therapy clearly shown the benefit with reference to the reduced ejection fraction failure. So heart failure, we normally put the patient on ACE inhibitor, angiotensin, we updated the dose, then we add beta blocker, melanocortical receptor in the order, right? Propose new sequencing based on the RCTs with reference to EMPA and DAPA. So put the patient on beta blocker and SGLT2 inhibitors. And next is angiotensin receptor neprilysin within a week time. And within a week time, please put the patient on melanocortical receptor. Over a period of 4 weeks, put the patient on 4 drug therapy, small dose. This will offer distinct benefit. So the new expert proposal for sequencing of heart failure, foundational therapy completed in 4 weeks. Step 1, simultaneous initiation. Step 2, within 1 to 2 weeks of step 1, ARNI. And within 1 to 2 weeks of step 2, step 3 is MRA. So this will give a very good outcome with reference to hospitalization as well as cardiovascular death and mortality. Next is diabetic kidney. So we have the normal kidney. Normal kidney, you see the glomerulus, the basement membrane, the podocytes, the glomerulus structure, Bowman's capsule, as well as the tubule. Next is patient with the diabetic kidney disease. Change with reference to glomerular basement membrane, podocyte, and next is with reference to mesangial cell. Next is collagen, and changes with reference to the proximal tubule. Tubules undergo. And see the afferent arteriole and efferent arteriole. Afferent arteriole dilates, efferent arteriole constricts. This disparity increases the interglomerular pressure. So kidney protection with SGLT2 inhibition. So I have told changes with reference to afferent and efferent arteriole, interglomerular pressure. Next is changes with reference to glomerulus. So there is hyperfiltration, and whatever there is filtered by the glomerulus is absorbed in the proximal conductive tubule. That proximal conductive tubule is exposed to higher sodium as well as the glucose, naturally increasing inflammation, oxidative stress, increased demand for oxygen. And these are the changes we come across in diabetic kidney disease. When you put the patient on SGLT2 inhibitor causes afferent vasoconstriction and efferent arterial dilatation, reduces interglomerular pressure, and increases the sodium load in the distal conductive tubule. Thereby, it restores the interglomerular pressure and reduces inflammation. And very important thing is it also induces the release of erythropoietin, which in turn improves the oxygen carrying capacity, release hypoxia with a favorable effect. So SGLT2 inhibitors reduce the burden on the proximal conductive tubule. The proximal epithelial cells are overloaded with excessive energy. I told you, type 2 diabetes is characterized by hemodynamic overload as well as energy overload. And if you look into the changes in the microenvironment, there is a myofibroblast changes. That in turn reduces the release of erythropoietin. By putting the patient on SGLT2 inhibitor, it restores erythropoietin secretion as well as release. So SGLT2 inhibitor improves kidney outcomes in patients with the type 2 diabetes, consistent kidney benefits. So the kidney outcomes by baseline albuminuria. Patients with higher urinary albumin excretion, they are the ultimate beneficiaries. Patient with higher EGFR, they are the beneficiaries. So if you look into the overall A1, A2, A3, you can see the difference. And we normally say MACE, major adverse cardiovascular events. Here I have given MAKE, that is major adverse kidney events. That is the decline in EGFR greater than 50%, or progressive decline in EGFR, or end-stage kidney disease, or all-cause mortality. There was 32% reduction in the risk of kidney function events with EMPA. So among patients with the type 2, EMPA use was associated with the EGFR preservation, very important. And it also slows down greater decline in EGFR. So next is reduction in BMI, reduced risk of MAKE, that is major adverse kidney events compared with other non-ACLT2 antihyperglycemic treatment. So ACLT2 inhibitor use results in 58% lower risk of serious kidney events based on the Scandinavian real-world evidence. So if you look into the serious kidney events, EMPA treated compared to DPP4, DAPA treated compared to DPP4 inhibitors. So in this analysis, using nationwide data from 3 countries, use of ACLT2 inhibitors compared with the DPP4 was associated with significantly reduced risk of serious renal events. So major studies with ACLT2 agents based on the kidney disease improving global outcome, KDIGO categories. So we have the G1, G2, G3A, B, as well as G4 and G5 with reference to glomerular filtration based on the albuminuria stage A1, A2, A3. And that what is seen in here, ECD, that is with reference to the cardiovascular outcome trial, EMPA, CANA, and D, ECD. And with reference to credence, that is patients recruited for the credence trial, that is CKD only. EGFR between 30 to 90, DAPA CKD, you can see the CKD as well as EGFR as well as EMPA kidney with reference to EGFR category. So the proposed renal protective pathways, one is it reduces blood pressure, potential direct cardiovascular effect, reduces intraglomerular pressure, loop diuretic sparing effect, that is differential volume loss, reduces albuminuria, improves oxygen delivery, oxygenation, and it has anti-inflammatory as well as antifibrotic, and above all, it improves the metabolic parameters, right? So the effect of SGLT2 on major kidney outcomes. So if you look into the events and the patients and the relative risk and the hazard ratio with reference to all the parameters, patients treated with the SGLT2 inhibitors showed remarkable improvement. So SGLT2 inhibitors have demonstrated clinically meaningful kidney outcomes even in studies involving patients with type 2. Patients in the EMPEROR, non-diabetic. Next, DAPA CKD and DAPA heart failure, non-diabetic patients. They also showed benefits with reference to the SGLT2 inhibitors. So EMPA kidney trial, that trial was stopped due to evidence of efficacy. And in fact, EMPA kidney, they recruited patients even with the EGFR of less than 20 and urinary albumin excretion less than 200 milligram per gram creatinine, right? So SGLT2 again showed clinically, reduced risk of incident and recurrent nephrolithiasis. So if you look into the Eris standard of care with reference to the patient category, first line therapy depends on the comorbidities. So when we come across patient with ACVD or CKD heart failure risk, put the patient on SGLT2 as monotherapy. Next is Heart Failure Association of the European Society of Cardiology. So assessing the landscape of the use in the prevention as well as treatment of heart failure, they have prescribed, they have recommended CANA, DAPA, EMPA, or etegliflozin. They have consistently demonstrated to be effective for the prevention of heart failure. Next is the combined ADA and KDIGO guidelines for the use for glucose lowering. That is standard of medical care in patients with type 2 diabetes with CKD. So metformin lifestyle changes and indicators of high risk or established cardiovascular disease, SGLT2 inhibitors with the proven or reducing CKD progression. Again, clinical practice guidance for patients with the type 2 diabetes and CKD when we want to achieve. That is, when the patient is already on metformin, you can add SGLT2 inhibitors. RSSDA, Endocrine Society of India, therapeutic wheel, again highlights the indications with reference to SGLT2 inhibitors and GLP receptor analogs. So SGLT2 inhibition improves hemodynamic parameters in patients with the type 2 diabetes, leading to cardiorenal protection. So remember vascular euphoria? That is the cardiovascular effects of SGLT2 inhibition. E stands for endothelial function improvement, utilization of energy substrates, pressure and volume offloading, hemoconcentration, oxidative stress reduction, reverse left ventricular modeling, inflammation control, and autonomic balance. So the priorities always take into consideration the risk factor, weight management, glycemia management, blood pressure management, lipid management, as well as CKD management, with a view to offer target organ productions with the aim to improve the metabolic parameters, cardiovascular as well as renal. So the CVOTs have raised expectation that newer glucose lowering agents should offer advantages that extend beyond glycemic control and weight management to address complications and comorbidities of type 2, particularly cardiorenal. And SGLT2 inhibition, holistic cardiorenal outcome, short-term effects and long-term effects. Short-term effects, purely hemodynamic and metabolic, and long-term effects with reference to blood pressure and lipid profile and with reference to ASCVD. So improved compensation for diabetes or blood pressure is probably associated with better long-term outcomes after SGLT2 inhibition. Now, let us come to the topic of this day. Can we consider SGLT2 inhibitors the statins of the 21st century based on the evidence so far I have presented? So in 2015, the results of the first large placebo-controlled SGLT2 inhibitor clinical outcome, EMPEROR outcome, in patients with type 2 and cardiovascular disease and reduced ejection. It showed EMPEROR resulted in a significant 14% reduction of primary endpoint. Even more exciting were the 32% reduction in death from any cause and 35% reduction in hospitalization for heart failure. So findings were soon confirmed with CANA and DAPA, leading to the first major paradigm shift affecting the clinical practice. So SGLT2 inhibitors are not only glucosiluric, but also reduce the development and progression of heart failure and prolong life in patients with the type 2 and reduced left ventricular ejection fraction. There followed 2 trials on patients with a history of heart failure with reduced ejection fraction, DAPA and EMPEROR, both of which showed equal benefits in patients with and without diabetes. So these observations led to the second paradigm shift. That is, it improves outcomes in patients with reduced ejection fraction, irrespective of presence or absence of type 2, thereby greatly expanding the potential target population for these drugs. Next is SOLIST, sotagliflozin trial. Demonstrated patients with type 2 and reduced heart failure across a full range of ejection fraction, including small subgroup of patients with preserved ejection fraction. So in the EMPEROR Preserved trial in 2021, extended the improvement in outcomes in patients with preserved ejection fraction to patients with type 2 diabetes, leading to third paradigm shift. That is, SGLT2 inhibitors appear to be beneficial in patients with chronic heart failure over a wide range of ejection fraction, again, greatly expanding the target population even further. So patients with the type 2 of longer duration, they carry high risk of developing diabetic renal disease. So it causes constriction of the afferent arterioles and dilation of the efferent arterioles. These changes result in reduction in intraglomerular pressure, hyperfiltration, and later responsible for glomerular fibrosis and diabetic renal dysfunction, ultimately end-stage renal disease. So the above-mentioned trials of SGLT2 in patients with type 2 diabetes and heart failure with reduced ejection fraction, combined with the 2 trials on patients with chronic kidney disease that included patients without diabetes, they exhibited substantial significant renal protection, leading to a fourth paradigm shift. That is, SGLT2 inhibitors slow the development of end-stage renal disease in patients with chronic kidney disease. So the benefit of SGLT2 inhibitors in patients without type 2 with a variety of chronic disease is under investigation. So the management of type 2 diabetes, of heart failure in patients with and without type 2, across a wide range of ventricular function, as well as diabetic renal disease, have all been substantially improved by the development of SGLT2 inhibitors. So the researchers recently posed a question: could flozins be the statins for risk-based primary prevention of heart failure? Can now be answered affirmatively. I hope Chairperson will also agree. Right. So before I conclude my talk, may I request all our delegates on behalf of the organizing committee of RSSDI 50th annual meeting to register your name for this event, which is going to be held in Chennai on 6, 7, 8, 9 October 2022 in Chennai Trade Center. So I request all our members to register. Those who have not become member of RSSDI, If they become life member before this month, you are eligible for pre-registration for RSS Day 2022. Thank you very much for the kind listening. Please remain safe, take care, stay healthy, protected, and connected in the days to come. I thank Eris for the kind invitation.
So great. I think it's not, it's a postgraduate lecture on executive inhibitors, not for the delegates. But anyway, I think it is far beyond. I will say it is not statin, it is more than statins, because statin is only for cardiovascular disease prevention, that is anti-atherosclerotic. But statin is a very wide spectrum. So what is called this cardiovascular renal metabolic axis of diabetes. Whereas statin is only cardiovascular. It is cardiovascular renal metabolic axis of the diabetes is touched upon by these SGLT inhibitors across a wide spectrum of conditions like diabetes control, heart failure, MACE reduction, and kidney disease management. So definitely, I will say confidently and vehemently that SGLT inhibitors are statins of the 21st century, but more than that, I will say it's more than statins to be utilized by every practitioner of taking care of diabetes patients and every specialty. Open.
Sir, good evening.
Very good evening, sir.
And about this automaticity of the cardiac muscle.
Pardon, sir?
Automaticity of the cardiac muscle.
Yes, sir.
Leaky sodium channels are the cause.
Pardon, sir?
Leaky sodium channels.
Yes, sir. Leaking sodium channels. Yes, sir. Of
Yes,
course.
Yes.
Yes, there
And
are.
less,
Yes.
less resting membrane potential. That is also another cause.
Yes, sir. Multiple factors have been incorporated with reference to arrhythmic potency in a patient with diabetes.
Yes,
One such is changes with reference to the various channels. Certain channels are overexpressed, upregulated, certain channels are downregulated. Of course, if you look into primarily, diabetes induces metabolic changes, structural changes, hemodynamic changes, and of course, functional changes. And with reference to arrhythmic potentiality, it produces primarily electrical alternates, electrical changes also. So these various parameters, but say diabetic patients, they are prone to develop arrhythmia. And patients presenting with cardiac autonomic neuropathy, the symptoms of first episode of atrial fibrillation may not be felt. It may be silent. So it increases the mortality also. So it can also precipitate cerebrovascular accident.
Nowadays, I am facing more patients with heart rate below 60 and above 50. But they are very stable. Is there anything to do with that?
No, sir. As long as the patient is stable, never disturb.
No problem.
Never disturb at all.
Not
but the
less
thing
than
is,
40, not less
stable
than
by definition is not a clear definition. Stable by definition. If you look into the New York Heart Association class 2, they say it's stable. Despite stable, they put the patient on 4 drug therapy: a diuretic, a beta blocker, plus ORNI, plus MRA.
Diuretic Lasix will lead to hyponatremia.
Yes, sir.
Lasix and water we say husband and wife.
Yes, sir. The classical furosemide,
Yes.
it reduces both intravascular as well as interstitial.
Yes.
In contrast, SGLT2 inhibitors, it produces differential volume loss, namely interstitial predominantly, no intravascular effect at all.
And about this HDL and LDL.
Pardon, sir?
HDL and LDL. LDL.
Yes, sir.
LDL mobilizes fat from lipids, fat from liver, and stores in the vascular endothelium. And HDL is a reverse action, does a reverse action. It mobilizes the fat or lipids stored in the endothelium of the vessels back to the liver.
Yes, sir. Actually, if you look into SGLT2 inhibitors, it has an impact on the lipid profile, no doubt at all. It Actually, it converts atherogenic LDL into less atherogenic. That's all.
Yes, that's all. Not on LDL.
LDL, it converts.
HDL.
That is, it makes small dents into large and buoyant.
HDL or LDL? Where
LDL, LDL, LDL,
LDL.
LDL.
Okay, sir. Thank you, sir.
Okay, if there is no discussion or questions, I thank the speaker again for his voluminous presentation and thank Eris Pharma for the nice occasion and also the organizing committee. Thank you.
Thank you very much, sir. Thank you so much.
So thank you very much, Doctor, for your excellent deliberation of your speech. So kind of you. And we would like to facilitate with a momentum. And sir, fine. வாங்க sir. Please come, sir. No issues. Yeah, come. Yes. Right, sir. Yeah. Done. Right. Please. So it's a pleasure having Dr. Sridhar. Thank you so much. Please sit down, sir. Yeah. So Dr. Sridhar will facilitate Dr. Gopinath. Thank you so much, sir. Thank you very much. Yeah. So thank you once again, sir, Dr. Shanmugavel, doctor, and Dr. Gopinath, Dr. S. Sridhar. Yes, thank you so much.
I haven't heard about any problem with diabetes problem in lungs. Only infections.
No, sir. It produces changes with reference to microangiopathy complication.
Yes.
That in turn will interfere with the oxygen perfusion capacity within the lungs. So pulmopathy. But only limited data are available.
Yes, sir. Yes, sir. Thank you.
So thank you once again. So it's thanks all from Eris, and I wish all the doctors a great evening. And once again, welcome you all to the temple of Meenakshi Amman. Thank you so much. Thank you, sir. Thank you, sir.
I am chairperson.
Super. Thank you, sir. Thank you. So kind.